Now, I'd like to compliment the speakers for being so timely. We'll have a lot of time for discussion. The final presenter in this panel this morning is Dr. Joan Keutzer, who is the Senior Director of Lysosomal Storage Disease Diagnostics at the Genzyme Corporation and has been very active in obviously the diagnosis and so forth of these folks and so forth. And Joan this morning is going to talk about newborn screening for the lysosomal storage diseases. Joan?
Thanks. Can everybody hear me?
Good.
Now can you hear me better? Okay. First, I'd just like to thank you for inviting me here to speak today. It's a real honor to come and talk to a group of people that aren't scientists, but are actually the patients and the advocates for Pompe disease. And when I tried thinking about what you'd like to hear about newborn screening for the lysosomal storage disorders today, I actually decided to start by just saying, what is newborn screening, and then give you a little bit of knowledge about what's happening in newborn screening using the U.S. model, but really this is a model of what's happening worldwide. Then talk a little bit about methods that you might be able to use for newborn screening for the lysosomal disorders, followed by some results of pilot programs for LSD newborn screening, and then end with Genzyme's commitment to facilitating newborn screening for the lysosomal disorders. So what is newborn screening? Newborn screening worldwide is a public health program, and the health program screens all infants born in a region within a few days of their birth for a set of diseases. The goal here is to identify patients with and then diagnose patients with life-threatening diseases or genetic diseases before any symptoms begin, and then initiate the appropriate treatment so that the patients have better outcomes. The panel of diseases included in newborn screenings varies widely, and it used to in the United States, and you'll see how that's coming together, but it varies widely in the world. In the U.S., the panel of diseases is decided on a state level, and outside of the United States, it's on a regional or a country level. So how do you decide, or how do these advisory committees or panels decide what diseases to include in newborn screening? Well, the disease has to be able to be identified biochemically before you have clinical symptoms. There has to be a demonstrated benefit of newborn screening. In some regions of the world, this benefit has to be to the individual. In other regions of the world, it's expanded to include benefit to the family. And this definition is expanding right now to include that the potential benefits of early intervention can be tested in a clinical study, and this is how the lysosomal disorders would be included in newborn screening. Of course, there has to be a test that you can use that's inexpensive so that you can actually do the screening. And in the past, it's been important that the incidence of the disorder is high enough to make universal screening worthwhile. So starting in the 1960s, when newborn screening was first introduced, until very recently, in the late 1990s, most newborn screening programs only screen for 3 to 6 disorders. But right now, newborn screening disease panels are expanding rapidly. And there's really 3 reasons that I can come up with, and there's probably a lot more. But the first is that medical research has led to the development of treatments for disorders that weren't treatable in the past. There's a lot of new technology that allows you to screen for more than one disorder in a single test, so the technology facilitates adding things to the panels. And I think a really important thing with respect to expansion of newborn screening is that families are becoming active, and they're lobbying for the diseases that are affecting their children to be included in these newborn screening panels. Right now, the number of diseases that are included in newborn screening panels is expected to increase. These panels are no longer considered to be static. In many countries, including the United States, the Netherlands, Japan, the UK, are evaluating their newborn screening programs to decide if and how they should expand their panels. So what I'm going to go over now is what's happening in the United States. In 2002, one of the divisions of the Department of Health and Human Services gave a grant to the American College of Medical Genetics and asked them to suggest a uniform panel of disorders to be included in newborn screening. They did this because, you know, if you were born in the state that I was born in, Kentucky, you would have been screened for 4 disorders as a newborn. But if you were born in Massachusetts, where my children were born, you were screened for 54 disorders. And, you know, being the United States of America, it was thought that wouldn't it be nice if every baby was screened for the same number of disorders. So the American College came up and recommended a core panel of 29 disorders, 25 secondary targets, which you would identify during the differential diagnosis of the primary targets, and then they hit a group of disorders that they said weren't currently appropriate for newborn screening. The lysosomal storage disorders and Pompe disease were part of this set of conditions, and that's because they were considered candidates for newborn screening, but there was no test that could be used for population screening available at the time. What I'll show you later is that there are a few tests right now. But to continue with what's happening in the United States, in 2004, an advisory committee on heritable disorders and genetic diseases in newborns and children was established. We happen to have the honor of having Rodney Howe, who's the chairman of that committee, in the room with us today. The goal of this committee is really to advise the Secretary of Health and Human Services on the most appropriate applications of newborn screening. So they were asked to recommend a uniform condition panel, and they have endorsed the panel that was recommended by the American College. They need to look at model policies and procedures for state newborn screening and consider if there should be national oversight, because right now each state decides what is in their own newborn screening panels. And they're asked to put together a decision matrix for the evaluation of these newborn screening panels and how you would add other disorders. So this is an ongoing process, and I think really good things are coming out of and will come out of this process. So to switch gears here, why are the lysosomal disorders considered candidates for newborn screening? Well, if you just go back, all this is substituting LSD into the criteria for newborn screening. So first, the patients are usually normal at birth. The disorders are progressive, debilitating, and often life-threatening. Correct diagnosis can take many years. There are treatments available for some of the lysosomal disorders. And most importantly, it's thought, and I think that after you think about the results that Nina, that Sang, that Bob talked about, and probably what was talked about yesterday, but I wasn't here, is that it's believed that early diagnosis and intervention might make a significant difference in patient outcomes. But of course, this magnitude of a difference can only be determined through newborn screening, and it remains to be determined. And I have to say, although I already talked about these tremendous advantages that there could be with LSD newborn screening, we also have to recognize there are some challenges. The first is that, you want to avoid treating patients earlier than is necessary. So it's desirable to have other assays where you can predict disease burden. It would be desirable to be able to discriminate early onset from late onset disease. It would be desirable to discriminate phenotypes that affect your cognition and your CNS from the ones that don't. And we have to recognize that newborn screening for the LSDs could identify asymptomatic individuals. Now, none of these are things that would, cause us to say we shouldn't do newborn screening for the LSDs, but we really need to be thoughtful of these as we introduce newborn screening for the lysosomal disorders. So what's Genzyme's role in LSD newborn screening? Well, starting in 1999, we've been sponsoring method development for a test that you could use for universal screening. And now we're sponsoring evaluation of these methods by newborn screening programs. Today I'm going to show you some results of the Pompe disease pilot program in Taiwan, and I'll show you at the end some results for Krabbe disease newborn screening that's happening right now in New York. So this is just to take a step back, and I was trying to figure out how to explain to people who aren't scientists of what you would do for lysosomal newborn screening. So up here is my version of a carrier or an unaffected person. So the substrate, which in the case of Pompe disease is glycogen, will go to the lysosome, and GAA, or lysosomal alpha-glucosidase, would degrade that into a product. That product goes on to be recycled, and this is what happens in the lysosome. Well, in a patient, they either don't have GAA or they don't have enough GAA, so what happens is that you get the substrate accumulating. Whatever GAA they have continues to make product, which is glucose. That glucose continues to be recycled. But what you have, because there's a stop here, you have a lot of substrate accumulate. So if we want to look for how do you screen for the disorders, we either have to, or two obvious easy things are to look for the accumulation of glycogen in the dried blood spots or the lack of enzyme activity. We spent a lot of time looking for ways to measure the accumulation of glycogen. We found ways that work, but they're not screening methods because they're not inexpensive, they're not readily adaptable to be high throughput. So then we switched to enzyme assays. So what I'm going to show you is the two approaches to measure enzyme assays and a few results that we've generated in newborn screening. The first way that you can do it is actually just using a miniaturized version of the diagnostic assay for Pompe disease. So what you have here is the readout is fluorescence, or the generation of light. So you have this molecule that scientists call 4-MU. If you put glucose on there, the 4-MU no longer gives off light. If you have the enzyme GAA in the sample, you can take the glucose off and make it generate light again. So at the end of this assay, all you look to do is to see, was the sample able to generate light from this non-fluorescent substrate? So you take a 3-millimeter punch of a dried blood spot, you put it in the well, you incubate it for 20 hours at 37 degrees, stop the reaction, and put it in a machine that measures light. Pompe patient samples wouldn't give off any light. Normal samples will give off light. This is the same assay that is being used at Duke right now to diagnose Pompe patients. And just to show you that the assay really works, this is just the sample of 300 or 150 normal samples that we ran in the assay at Genzyme. 58 late onset Pompe patients and 24 infantile onset Pompe patients. And what you can tell is this assay, based on the light that's generated, differentiate normals from the patients. We teamed up with National Taiwan University Hospital and established this assay in the Newborn Screening Center. They screened 45% of the babies born in Taiwan from April of 2005 through August of 2006. The same hospital is the referral center for the clinical diagnosis of Pompe disease for the whole island, so the rest of the island can serve in this model as a control. Just so you know a little bit about the program, we hung informational posters throughout the participating hospitals. Every family was given information. They were given growth charts and things to take home so they could reread it and understand what they were part of. And there was a lot more information available online. And we used informed consent for each sample that was collected in this process and for every assay that was done to those samples. So I'll walk you through this. This looks really complicated. It's a summary of all the data. So in those 10 months, 3 cases of Pompe disease were identified in the newborn screening population. And from the rest of the island, 3 cases of Pompe disease presented clinically. The first case of Pompe disease identified in newborn screening upon physical exam and doing the other lab assays, found that there were no cardiac symptoms, so it wasn't early onset Pompe disease, and they had normal muscle strength. As of September 1st, the child only exhibited muscle weakness, but now 2 weeks ago the child was actually put in the hospital, and I haven't heard if it's on treatment yet, but it really started. It is on treatment. The other 3 cases that looked clinically normal at birth were put on enzyme at 3 months, 5 months, and 2 months, and although they are improving on enzyme replacement therapy, what I'll show you in a minute is they're not actually doing as well as the children who started enzyme replacement at birth. So this is the 3 of the patients that live really close to NTUH and come for all of their infusions at the hospital that did the screening. These 2, and I see now this symbol doesn't match, but this is the newborn screening case 2. So newborn screening case 2 and 3 had enlarged hearts at birth, and the heart size is going down on enzyme replacement therapy. The one, clinical case 1, had an enlarged heart. It too is responding in size to enzyme replacement therapy. But if you look at serum CK, the 2 patients that started on enzyme before they were a month old, their CK is also coming down. And the one who presented clinically, their CK is not improving on enzyme. So what this tends to say, it's really early. We need to follow these children for years, hopefully in the Pompe registry, is that there is a benefit, this potential benefit for newborn screening for Pompe disease could be true. So that assay that I just showed you, the readout that you do is the generation of light. So it's impossible to do multiplexing or tests for more than one disease in the same test. So a group of researchers at the University of Washington came up with a way that you can screen for 5 different lysosomal storage disorders in the same test. So what you do is you take the same 3 millimeter dried blood spot, you just put it into a tube and add some liquid, and then once you wash all the blood off of the piece of paper, then you divide the liquid into 5 tubes. You do the enzyme reactions for the 5 separately, mix it all together, and then inject it into a mass spec. I'll try walking you through how this works. Hopefully it'll make it, you understand it. So whereas before you took this fluorescent molecule, put glucose on it, and stopped it from fluorescing, what they designed actually is a fancy handle that is a unique size. So, imagine if this handle was, we'll just pretend it's purple and it's 10 inches long. So if you have the enzyme, you would cut this blue triangle off of there and you'd have the purple 10-inch long handle. And then they have an internal standard that's 10 inches long and it's green that this machine can measure, and in the end all you do is, instead of measuring light given off, you see how much purple there was relative to the control thing that you put in there to say how much green is there. And it's just a ratio of things that lets you know how much of the product was made. So what they did was that they made each of the handles for the 5 different enzymes a different length. And so you have one that's 398, one 496, one 482, one 484, and one 498. So the product, instead of being light for the different enzyme activities, is just a different size. So you can measure all 5 of them at the same time. I have these targets for this enzyme assay divided up into groups. This is all of the lysosomal disorders that are considered treatable, except for Tay-Sachs. Tay-Sachs is on this list because the Minister of Health representative in Israel asked us to add it to the group when he saw us present this once. So what I'm going to show you is the results for these ones that were developed and published together, and that is a multiplex assay for Pompe disease, Krabbe disease, Fabry, Gaucher, and Niemann-Pick. The substrates for MPS 1 and MPS 2 are developed, and these are still being developed at the University of Washington. This is a transport disorder, so you really couldn't do an enzyme assay to look for it, but it is a treatable lysosomal disorder. We need to keep it on our list. So what we did once they published this assay was to say, how can we help take this published assay now and get it into newborn screening? So we decided we should bring it in-house at Genzyme and have a group of scientists make it a robust assay. So what does that mean? We tried to make it a high-precision assay so there wouldn't be a lot of false positives. We needed to make it a high-throughput assay. We need to have a reliable supply of the key chemicals, because all these chemicals I just showed you, they're not like the ones in a catalog, the ones that generate light, they're all new. And we decided that we had to work on quality control of the assay. To make this reliable supply of key chemicals, because they need to be manufactured in a GMP facility, we decided to manufacture them at our pharmaceuticals plant in Liestal, Switzerland. Then we did another thing, and we realized, we're good scientists at Genzyme, but we know nothing about newborn screening labs. We are not public health people. So we did an online survey, put it out there for the 43 public health labs in the United States. Almost 30 of them responded, and they asked us to address some environmental concerns to make it fit in their standard operating protocol in their labs, and to simplify the way the mass spec was done. So we went into our labs and addressed all these concerns. We tested, and I'm showing you right here, the new method with neem and pick, and what you can see is, yes, we did exactly what they asked us, but we could no longer differentiate the neem and pick, or the neem and pick, from the control in all of the samples. So we went back in the lab with all of the assays, and I'll just show you here. We did with the lowest controls, the highest patients, things like adding zinc to try to tease them apart, and it worked, and adjusting the pH to tease apart the controls from the patients. In all, I'm not going to read any of this, but these are the changes that we made to each of the published assays to make it work in this new multiplex format. Finally, we got to the point where we had 5 brand new protocols, and we wanted to test this master protocol then for all of the 5 diseases I showed you. We wanted to confirm the quality of all the materials manufactured by Genzyme, and of course then we had to test them on LSD. So we took 144 normal samples in a mixture of previously diagnosed lysosomal storage disorder patients, and in each case we were able to differentiate the controls. This is for the neem and pick assay, the neem and picks from the other LSD patients. So here it is for neem and pick, it worked. In the same assay, when you look at it for Fabry, it worked. When you look at the same assay for Pompe, it worked. For Krabbe, it worked, and for Gaucher disease, it worked. So we are really satisfied now that we modified the method, we made it more compatible with newborn screening labs, and we are still able to differentiate the patients from other lysosomal storage disease patients and controls. So what we need to do now is to validate the assay to make sure it's linear, to make sure nothing in samples can interfere with it, and we actually have to look at stability of the protocols, and we have to look at stability of all the samples and all the things you traditionally do to validate a clinical assay. We also wanted to take a first look at precision of the assay. So what we did is we had a single operator do this whole thing by hand, and over 3 weeks, every day, they tested our favorite 2 normal samples, which we called SO3 and SO6 and SO7 in our lab notebook. So they did a total of 192 tests on these individual samples. And what you can see here, you don't need to be a scientist to see that this is a really nice assay, because you get the same answer with the same sample over the 192 times. The assays all have right between 8 and 50% CVs, which is a really nice enzyme assay for use in a clinical lab. So we're satisfied that that preliminarily we know the cocktail is stable, because we made these on day 1 and used them for 3 weeks, and that the changes that we made to the assays have an assay that's pretty stable. But of course, like I told you, we're not a newborn screening lab. And so we were working with the state of New York, and their idea was to bring up the 5-plex, so the 5 disorders that I showed you. But of course, things never go as planned. And on January 6, 2005, the governor of New York made an announcement that by the end of the year, they were going to start screening every newborn born for Krabbe disease. So we worked with the Department of Public Health in New York. We transferred all of the assay improvements we did to New York. And in December of 2005, they started a population study so they could set their cutoffs for this assay in their lab. So they were running 1,000 samples a day. That's how many their newborn screening lab does. And this is in June, so every day from December to June is accounted for on here. And what you see is that the average daily mean of this assay stayed pretty consistent throughout the days. So what this means, what they estimated and why they went live with this assay this August 7th, was Krabbe patients are usually less than 5% of the average daily mean in this assay. And if they took the samples that they saw that were down in this part of the assay, they would have only been recalling 13 out of 250,000 samples in a year. Now, if you compare this to the other assays that people use in newborn screening right now, you recall around 1%. So this is 100-fold lower than the recall rate that newborn screening labs are accustomed right now. So they were pretty satisfied, and we were pretty happy that we thought that we transferred to them a really good assay. I talked to him last week to ask him if I could say what's going on now that this is live. And since August 7th, they have screened over 70,000 newborn screening samples, and they have only referred 8 of them on for a diagnostic workup. So as this was 100-fold better than any of the assays they had in their newborn screening lab at that time, it proved to be absolutely true that once they used it live in our reporting values, it still has 100-fold less false positive rate than the other assays. So finally, this is my last slide. I just want to talk to you about, what's Genzyme commitment to newborn screening for the lysosomal storage disorder. So Genzyme is going to continue to support lysosomal storage disorder newborn screening pilot programs. I showed you the results from New York. They want us to transfer the Pompe assay to them as soon as we have it ready. I showed you what we're doing with Taiwan. In Austria right now, they brought up the 5-plex. They're doing a population study to see how that method, using all 5 at once, not just Krabbe in isolation, will work. In Germany, they're doing a population study for Pompe right now. Interestingly, it's not on here, but the state of Illinois, there's a father who has 3 children with MLD, and he has gotten a coalition together. It's made of Pompe families, Krabbe families, and the MLD families, and they're really pushing the Department of Public Health to start up newborn screening for Pompe and Krabbe disease, so we might be transferring these assays to them pretty soon. We're going to work with the CDC to make the reagents that you need for that multiplex assay available without charge. So I already told you we're manufacturing at Genzyme Pharmaceuticals in Switzerland. We are going to register the reagents in the U.S. and Europe. So they'll get a CE mark, and they'll be registered as analyte-specific reagents and recognized by the FDA. The distribution will be by the same branch of the CDC that is responsible for QA and QC of newborn screening assays worldwide. And they should be available for use for reporting newborn screening in late 2007, early 2008. But I think a really important message is that, technology cannot be the driver for newborn screening, but it is the first critical step. So Genzyme is going to continue to facilitate newborn screening technology development for all the treatable LSDs, and we will also continue bringing the appropriate parties to the table so that they can make the decisions of how to include the lysosomal storage disorders in their public health programs. And one of the things that we're going to be doing in 2007 is giving a grant to the American College so that they can bring a group together to establish diagnostic and treatment guidelines for children identified through newborn screening that have lysosomal storage disorders. I'm sure you got a flavor of it from what I've been saying. You know, this work that I've showed you has been an enormous and fun international collaboration between Genzyme, the Taiwan Newborn Screening Lab, the Austrian Newborn Screening Lab, the New York Newborn Screening Lab, the group at the University of Washington, the CDC, and, you know, lastly, I just need to mention, I'm sure none of you realize, but the person who made the breakthrough discovery that allowed Pompe disease to be included in newborn screening passed away last May. So, unfortunately, he's not here to be so proud of what he did, but I think we still need to recognize him for his contribution. Thank you.
So after lunch, if all the patients would go to the next room, and of course anybody else that wants to attend should come also. I just wish to thank all of the excellent presenters, and we can all realize that, as we said earlier at the beginning of the conference, there are many more steps that have to be taken, many more steps, and I'm sure Genzyme will do this, and others of us as well will participate in guiding this steps. Other than that, Marcia Zimmerman is going now to make the, going to do the wrap.
I wanted to thank Arnold Bruiser for being our Master of Ceremonies, and I'm sorry I didn't give too much information. And truly, Arnold was on his own. We said do it, and he did a wonderful job. And I'm so glad that he really enjoyed the poo down.
I don't think I need that. Okay, before I do the raffle drawing, Don Phillips made some handouts for late onset patients on physical therapy and exercise. And if you go in the back row on the blue binder right in front of the Coke machine, you'll see them stacked up there, all right? Okay, are we ready? In the back of your program is the listing of what's in the actual raffle baskets. I'm not going to read what's in there. Unless you want me to. Okay. Now, this is Miss G Nation just pulled her name for. Is this a? How many did you? We should have her.
Marcia, what number was that?
9. For basket number 8, Carol Kunkel. For basket number 7, Trevor Perry. Is Trevor in here? Oh, there he is. Congratulations. This you can take back to your teacher. There's your boss. Got it? There you go. Congratulations. For basket number 6, Jamal. Calvin Knoll. Yay, Calvin. Calvin the cowboy. I think we Texified him. Congratulations, Calvin. Yay. Isn't that great? Yeah. Okay. Basket number 5.
Anybody want to give me a quarter to pull their name? Pretty good.
Nancy Cisneros. Now for the 4, 3, 2, 1. These are, okay. Do they have to be? They have to be grand prize eligible, right? All right. For the next 4, it's where you had you mark, are you eligible for the grand prize or not? And so you may take a couple to get these out. Basket number 4.
There's 2 there.
And this one is Karen and Corrine and Ron Skelton. You get basket number 4. Congratulations. Quick, run down. Get a refund. For basket number 3. Only one per family. Calvin Knoll won again. Okay, Calvin. Geez, you're lucky. Come on back up. You are a lucky boy. You should have him playing the lotto, I think, you know? You get a free night at the Holiday Inn and whatever else is in there. Good job. No more for you, though. Basket number 2. Carol Kunkel. It pays to throw a lot of them in there, I guess. Okay, and the last one. Christine Moscow. Yes. Thank you so much.
I think we go for lunch and then reconvene at that site. This is one of the last slides. It's 10 years AMDA and IPA, and they did extremely well. And I was really honored to be the master of ceremonies. So thanks for this fascinating meeting. And of course, that first of all goes to Marilyn, Tiffany, Randall House, Marcia Zimmerman, and all the others, also the IPA members, all the speakers, and the patients, the audience. We really did it all together, and it worked very well. So, thanks to everyone, from everyone.
I'm Dee Dee Burroughs, if y'all had to figure out, I'm Morgan's mom. And she was actually diagnosed at, I think it was 20 months, but we saw symptoms pretty early in life too, probably as early as maybe 6 months. We knew that something was way wrong, and we saw a pediatric neurologist at about 16 months, and she was initially diagnosed by muscle biopsy, Children's Hospital in New Orleans at 21 months. And we started getting my enzyme on December 29th of '03, and it's changed her life quite for the better.
Alicia, do you want to introduce yourself?
Oh, my name is Alicia Blackington. I'm from San Diego, California. Marcia Zimmerman kind of got me as a mentor for the new people that come into the GSD, and I do chat quite a bit with everybody internationally. I've had the privilege to know Jerry Sabato quite well. He's not here just yet.
He asked all the questions today.
Yeah, he asked all our questions today. Brian White, myself, Jerry Salvato, and David Hamlet from the United Pompe Foundation collaborated a few years ago and did a patient conference in San Diego. we missed you all. We're possibly even trying to collaborate another patient conference in the next year or two. We decided not to do anything right now because of the LOTS trial and the time situation, because we're all going there every other week, and it was just too chaotic at this time. So maybe we can bring that up together, talking about a patient conference for 2008, just to get together and talk about daily challenges, family support, family issues, caregiver issues, and there you go. And I'm 41 years old and pulmonarily affected, but physically I'm pretty good. There you go.
People there and recording them, they would make as well.
Sure. My name's Scott Eggers. I'm 39. Been diagnosed officially with Pompe's about 9 months ago, but have had symptoms going back to my teenage years, and really started at birth actually. In terms of vital capacity, very much like Alicia, very diminished over the last 2-3 years, rather significantly, but physically still very active and able to do most things. Only challenge is really vertical climbing, which is very common, of course, and getting up from the ground level. Lifting or getting up from the ground is my two main weaknesses.
My name is Ron Eggers. I'm currently coming to my third infusion this Tuesday. As far as disease, I was severely affected by age 29 with respiratory. I actually went into respiratory failure before I ever got diagnosed with Pompe disease. So I trashed and burned real hard. I was affected. I trashed and burned real hard before I even known that I had disease. So, but for me, it's been almost 15 years struggling with the breathing. The walking gets worse and worse year by year. So, but I'm grateful that my Enzyme is around, and hopefully I can get stabilized to the best. And a little wishful thinking, maybe some improvement. I hopefully, I would like to see that, but I'm not going to guarantee it.
My name is Michelle Presley. I have a 2-year-old little girl with infantile disease. She's on a ventilator. She seems to be one of the more severely affected. She was on a 1602 study and she started at 2 months old. Did everybody hear me? My name is Michelle Presley. I have a 2-year-old little girl who has infantile Pompe. She seems to be one of the more severely affected children. She was on a 1602 study and she started at 2 months.
Where are you from?
Birmingham, Alabama. She is on a ventilator.
But I think in terms of format, we were hoping that this would be as casual as possible. So just kind of maybe get the discussion started and to see where the wind takes us. I was curious, of the patients, how many people are on therapy now? Or think they're on therapy, I guess. And how many aren't on therapy that have the disease? Well, in terms of maybe the way to start in terms of discussion would be those who are, and maybe briefly, people want to share any experiences, how they're doing. I've had 5 infusions, 5 maybe 6, and so number one, no infusion-related issues, no rashes or anything like that. But I've started to notice a little bit of incremental progress, in terms of getting sentences out fully without having to take multiple breaths, and I noticed just, playing basketball in my driveway with my kids last week, noticed I was able to get through that in about half an hour without having any major problems throughout the last year. That was a stretch, so at least my experiences so far have been so far so good.
My experience is that I'm already being treated for over 3 years, and I was what you call severely affected. I didn't have tracheostomy because I refused one, so I was on non-invasive ventilation, and I noticed my first change after 10 months of infusions, that I wasn't tired anymore. Normally I have to go to bed in the afternoon because I simply was too tired. And one afternoon I was in bed and I was thinking, my God, what am I doing here? Because I'm not tired at all. But we were so used to go to bed in the afternoon that it was more a ritual than, it just happened. And then I decided not to go anymore. From that moment on, I didn't go to bed anymore in the afternoon. I also noticed a better breathing. I cannot say I'm off the ventilator, I'm not. But just the fact that you can be off the ventilator more often is already a huge improvement. Just the fact that you're able to shower normally without being out of breath is so important, being able to use the toilet without being out of breath. There's all simple daily tasks, but they're really a huge improvement in life. And I think that without my enzyme, I would not be able to make the huge trip from the Netherlands to San Antonio. So that's for me a huge improvement. Other people want to say something?
My daughter's Katie, and she's 29. She lives in Alaska, so she didn't make it down here, but she's been in clinical trials. Hello? And she's shown a lot of improvement. She's been on for about 10 months now, and she can walk farther. She's not on a ventilator yet, and she can pick things up where she couldn't before. She can't get up when she falls yet, but she's doing quite a bit better.
Hi, I have 8 infusions under my belt, and I'm actually going to be infused on Wednesday. I don't notice anything outright, but I have had significantly less headaches, and I've also used a lot less ibuprofen. Normally I take ibuprofen every single day, multiple times a day, just to simply take the edge off of some leg pain and back pain. And I've had inconsistent usage of that, so there have been a couple of weeks where I've gone a whole week without using it, so that's been a real positive.
Pre-med her now, so she hasn't had that since. But she has, sometimes within the 30-minute to 1 hour range, she'll have an immediate sunburn, and it'll go away, the next 30 minutes to an hour. What else has she had? Sometimes she'll look very, very pale and clammy, and she'll get that, she'll get cyanotic around the mouth, and look gray and blue. She'll drop her sats for, within that 1 hour period, and then she'll come back up. I just wanted to know if any of the other children or adults had those kind of reactions.
I didn't have any reaction.
The woman, no, she's not here, that somebody brought up, who was in the Pittsburgh last trial. She had to pull out, but she did have a similar reaction. And she, I was going to say she went into cardiac arrest.
We can't hear you, Brian.
I'm sorry. The woman, I think her name is Michelle, maybe?
No, Danny.
Yeah, she was in the Pittsburgh trial. They were here, but she had a problem and had to go into join the shop, respiratory arrest, and they had to take her off the enzyme.
Ron's been on ERT 1 year and had 0 reaction.
It's a totally uneventful event for him.
Katie does the flushing, she turns bright red.
I've been on for 7 years, and I haven't had any reaction, but I have had positive. I was very severely affected when I started, and I'm much stronger. I feel much better than when I started.
Morgan has been on treatment, not quite 3 years, it'll be 3 years next month, and we've seen a tremendous improvement in her as well. She was homeschooled and really spent a lot of time in bed like you did. I would force her to get up in the morning at about 11 or so to spend about 90 minutes of school with her home-based teacher, and she was crying and was hurting and wanted to go back to bed about 3 o'clock in the afternoon, and that has all stopped. She's very vibrant and spends her day, like you see here, very energetic and happy and feels good. And so in that sense, she's done very well. She has a life, so friends at school, she attends school. She does pretty well in 5th grade. You what? You used to go what? She used to attend school half a day, and she's graduated to a full day of school, and she tolerates that very well. Do you want me to say something, please? No? Okay.
I have a question. One of the issues I've had with the enzyme is just the whole process. You know, the infusions are 4 hours, and I guess it takes somewhere around an hour to mix up, but at least my experience is, and it's in a fairly large hospital, and you know, I'm one of probably 10 people being treated in the infusion center, so, and there are people in much worse shape than I am there with other diseases. So the pharmacist can often take 3 hours to get the enzyme ready. So you're talking about, you know, traveling to, you know, a place, you know, a large hospital, waiting, and then getting 4 hours, and then trying to sneak out before the nurse sees you when you're done. So you don't have to wait 2 hours or time after. I'm wondering if anybody, maybe even the folks who are further along in the process, has developed relationships with the hospital folks to expedite that. I've heard people say they call the pharmacist on the way in or something, and they've been able to kind of trim that time down. Does anybody have any tricks? $100 bill will do it.
Brian, as a patient care liaison in LA, I've got 2 large university centers that treat adult patients with Pompe. And developing a personal relationship with not just the scheduling nurse that makes your appointments, but also the pharmacist is something that I've always encouraged. One of the pharmacists actually encourages our Pompe patients to call when they're leaving the house. Not that they're going to start mixing before the patient shows up, but at least then they triage that patient appropriately, because they know that you're going to be there for 4 to 5 hours being infused, and then another hour to 2 for observation. So that has helped. It doesn't work in all situations, but I would encourage you to develop a relationship and make sure that you schedule your next infusion before you leave, and then schedule it, or even have a standing appointment for your infusion every 2 weeks with the scheduling secretary. It's not a bad idea to make friends with the staff.
Muffins, chocolate, flowers.
Well, it's Christmas time.
Yeah, I know. You know there's going to be plenty of stuff going on.
Yeah, I was taking donuts.
Yeah.
Along the same line, Katie travels from Alaska to New York City every other week for hers, and she's getting hecked by the TSA people. I mean, the body pats every time, and turning her scooter upside down. What can we do? I travel a lot, and you know, what can you do? The best thing you can do is
try to be nice. And I know, but that's really, I experienced that when I once arrived in New York and I was shocked. It was absolutely not warm welcome to the United States. And just by the TSA people, the rest was all, everyone was great, but they were terrible. But it also differs from where you enter the US, because I experienced in Chicago, Minneapolis, the welcoming was great. In Chicago, I went to a biotech conference and the lady of the TSA asked me, what are you doing here? I said, we are for the biotech conference. Oh, really? Not, she really wants to know everything about the disease. It was great, it's so different. And you just have to go, try to accept it as it is.
One time, the person at the gate in front of her, was buying a ticket to New York on the same plane, got on, and then the ticket agent said, we don't have any more, you're not going. And she missed her flight, missed her connection in Minnesota, added a whole day to her travel. It was horrendous.
And there's no possibility for her to treat in Alaska?
Well, they've moved her to Seattle for the regular, but she still has to do her checkups in New York.
What airlines is she flying?
Northwest and Northwest.
Does she have to fly that airline?
You can get a frequent traveler though.
Yeah.
She does. They won't give her the upgrades.
But I mean, like I noticed at Washington, there was 2 lines to check in. It was like super traveler, and then every other citizen.
She goes through those. She's just being terribly harassed at every leg.
I have to pat you down and said, this is nothing after the week I've had. I said, thank you for doing your job. And every time I do travel with the BiPAP, they have to examine. I always say to the staff, the TSA agents, thank you for doing your job. It's for the overall good of the community, humanity, that they are a pain in the you know what. But I just try to smile and say thank you for doing your job. I understand and be readily available for them. My traveling experience has been horrible because it's the passengers that don't see me, the travelers that don't see me, that have had 3 experiences where I've literally almost been taken out by big adults that are not paying attention and, hey, I'm down here, or they bump me with their luggage. It's the rudeness of the travelers that I encounter, not the TSA agents. And I'm so sorry for your daughter. That's just deplorable. It's unfortunate that she's having those experiences. Great tune.
Able to, once he got out of the expanded access program, the nurse that administers she got the doctor's approval, and we now adjust his increments in 15 minutes, and we now take him, and we have dropped out the middle. He starts out at 25, milligrams or milliliters per minute, and it goes from 25 to 45 to 115, and it keeps doubling, and then the last dosage is 245. We cut out those 2 middle ones, and so the infusion goes much, much quicker, and then by adjusting it by 15-minute increments, he's at his maximum infusion rate at a very quick, within 45 minutes, and we just run it at that, and it goes very, very fast. I don't understand about the pharmacy. Our pharmacist, I guess the Enzyme is good for 24 hours, and they make it up the afternoon before. And so, no.
Don't tell Genzyme that. This is all off the record, this discussion.
Yeah, no, that's okay. It's not likely they're mixing it the day before. I would be very surprised. It's not impossible, but it's not very likely.
Happens in England. So they mix the night before.
What happens if he can't make it because he's sick? And then
They called the day before to make sure he's coming.
Yeah, they called the day before to make sure he's coming, but I know it's being made the day before. Because we are at the office by 9 o'clock and it's in, ready to go at 9 o'clock in the morning.
That's on the third.
It depends on what their opinion is, but yeah, I mean, if they mixed it, they bought it. and it's-
So are you trying to say that the effectiveness is not?
No, it has a 24-hour shelf life.
So if he was
Right.
sick,
But if you got sick the next morning.
But if he happens to show up that morning and has a fever, they wouldn't be able to begin his infusion based on the fact that he had a fever, and they'd have to dump his dose.
Right. We are aware of that, and we are very careful with Ron's health.
Are you on commercial? Are you commercially receiving Myozyme?
Yeah, oh, no, are you commercially receiving it, meaning your insurance company's being billed, or are you in a clinical trial?
Right, he just finished clinical trial and it's now Medicare's paying.
Oh, he is EAP then?
Yes.
Okay.
Why is it?
We have been talking about infusions, but I was wondering, because I'm thinking about it now, because I'm on 3 years of Myozyme, and what about rehabilitation and physical therapies? Are you in a program or whatever to increase your body strength? Do people have experiences with that?
Okay, this brings up a very good point. I was talking to Priya, and she said there's 2 publications that are out, and they have been approved by the American College of Medical Genetics, right? The guidelines for Pompe disease and guidelines for physical therapy management. I think these would be good resources for us because I think everyone does something different, and nobody knows exactly what we're supposed to do. But we will try to have access to this on our website and also on IPA. And then maybe there could be some kind of any kind of guidelines that all of us could use or follow, and things that would be helpful for these conditions. We'll put that on our homepage.
I do the Dr. Sloan routine. I don't know how many people have seen him, but he has a sub-maximal treadmill program. They put you on the treadmill and monitor your heart rate, your breathing, so on and so forth. And he takes you up to a certain level and then brings you back down. It's about 42 minutes.
and then I've been trying to do some weightlifting, really a bit small, as a 10-pound barbell, that kind of thing. Just figured you want to keep your muscles active to a certain degree. So but it's, yeah, like kind of Marilyn says, there's no real guidelines out there. We're just kind of going blind and hoping it works, or thinking it's helping.
How many of you on treatment, during the treatment, work out a little bit?
My infusion takes about 4 hours, and when I'm on a fast rate, so actually the last 2 hours, I exercise my legs for an hour. It means that I'm biking with my own strength, and I keep that up for an hour.
You exercise while you're getting your infusion?
Yes. My hospital was able to, because I was one of the first, and they were able to somehow borrow, but I don't know how long the borrow takes, because it's already for 3 years. But borrowed a bike, a ultimate Viva trainer, and I can use that. So, and I think it's very useful because, first of all, you're doing something, you're doing something during your infusion, and you're also exercising. So I think that's a good thing to do if it's possible.
Are you doing that involved in some way with what they were talking about this morning about doing some sort of exercise during the infusion to increase the absorption rate? I didn't know if that was the impetus for that or if it was... I was just wondering if you were doing that as like the question they asked this morning about doing exercise during the infusion to increase the absorption rate.
That's what we hope for.
The idea behind it was that when you use your muscles actively, the bloodstream circulation in your muscles is much better. So maybe also, the enzyme uptake might be better. But that's really something, it's only that we don't know for sure. But at the same time, even when you don't know for sure, it's good to exercise. So that's how I see it, and that's how I do it.
This is a hand bike, and I got it at a medical supply place, not too expensive. And I just try to pedal with my arms, and I use my legs, and then I stretch too, just keeping, movement and blood flow and all that Marissa already said.
How many of the adults here with Pompe have actually had fractures?
All lifetime?
Yeah.
Turn the last name.
Broke 4 fingers last year. Oh, how? I'm a mailman. And lifting up stuff.
I just was
broke 4
wondering,
fingers.
how many of you was it related to, physical trauma, where you would expect a fracture, or how many of it was related to minimal?
I have really severe osteoporosis. I take injections of Forteo every day. But I broke 4 fingers last year just lifting things, and my fingers would break. So
Mine doesn't count.
The reason I just bring this up is this is something that we have noted, and I think that as we are all talking about an exercise program here, I think it's very important that we know what the underlying bone density is, because of course with therapy you start feeling better, but it's still going to take time before you're strong enough to do, vigorous exercise. I think really getting that at baseline would be a very important part of it.
Well, I've had a total of 16 bone fractures in my life.
Oh,
Because I broke my femur and stuff.
No, I've had a total of 16 bone fractures in my life. Just various things at various times, but the 4 fingers last year was when I finally had a bone density test.
I also think you have to know it's not just adults. Trevor has had various bone fractures with doing very little to nothing. He did run his wheelchair in the back of a truck and broke his arm and leg, but besides that, and so now he's on Formigerate, which is an IV every 4 weeks. So it's not just adults, and we have to be aware of that.
I think it's true that we almost realize when you do have neuromuscular disorder, and not only Pompe disease, but all kinds, that the chance on osteoporosis is very high. I just went to a bone scan before I left to the US, and I don't know what the results are, but I know that you have to be very careful with your bones. And maybe I really recommend everyone to discuss this with your physician, to take at least a bone scan and see what's happening, and if you can do something with, or either calcium tablets or a medicine. Because it's really an issue that's very important, especially when you try to improve your physical health.
Just a word about Jamie. When he had his scoliosis operation, we were expecting it to be a lot more severe than it was, and the reason they used less rods in his back was that his bone density was very high. So, just to put the other point of view.
But he was still mobile.
Yeah, true. Absolutely. But that's, it's not Pompe necessarily. It's the inability. Yeah.
I wanted to ask Priya, in those reports that they're going to put up on the AMDA website, do they have specific guidelines? Are they just for adults or are there some for children? Because Bailey's had 3 femur fractures, and I know specifically that they came with, 2 of them came with physical therapy, working with her on other, they kind of go along with what they do for other neuromuscular diseases.
No, I'm glad you asked the question. These guidelines are really a consensus, so it's all expert opinion. All of it is not evidence-based because we do not have the evidence for everything that we recommend. But this was based on experts within the US and some from Europe also, and it's really for both infantile and for adults, so it's across the disease spectrum. And with regard to your question about fractures, that's what really got my attention is as we were doing the infantile trials, we had 4 patients who developed fractures, and 3 of them were, yes, completely immobile, and so I could understand why they developed fractures. So then we prospectively looked at patients who were being treated and who did not have fractures and had good mobility as they started, and to our surprise, actually even some of them had low bone density at the outset, so we've been able to compare it with normals. But what we've also been able to show in a limited number is an improvement in the bone density over time as they're being able to do more motor activity. I think the part which we all have to remember is that we also found some fracture of the spine, and I think that's very important for the developing children, because if you have a fracture of the spine and it does not heal appropriately, you can actually develop more kyphosis and scoliosis and long-term issues. So I really strongly recommend that this is part of the management plan.
Another question for everybody. Katie, I guess like all the other adults, drinks socially, and I don't recall whether any of the doctors have said anything about whether alcohol affects the ERT or not, or if there's any side effects above and beyond just regular alcohol consumption. Wondered if anybody had any experience.
Oh, yeah.
I do like wine.
So does she?
I do like wine. No, I never experienced any side effects. And actually, I had a few sips of champagne during my first infusion. So, and it did work well. But what I noticed by wine is that I get much warmer. So my idea is that because you feel much warmer, your blood circulation also goes better. So maybe there's a meaning. But I don't drink together with the therapy at the same time, of course. But no, I never ever experienced a contraindication for that.
Yeah, certainly my experience that if you drink, the next day you feel it in your muscles. So much so that when I do Pilates, they can tell. They push me to a limit where I can't do it quite as well. But I'd say I've had a drink and said, yeah, I can tell that. So, and you know, obviously it's a poison, so why wouldn't it hurt us?
Actually, Bruce and I talked about this last night, and I was saying that if I drink just even like half a drink, it makes it harder for me to breathe. And so I have a little bit, but typically no.
My experience has been actually a little bit like yours. If I'm just sitting at home watching a movie, I can drink till the cows come home. But if I'm walking around any distance, it really makes it difficult just to walk like 200 yards. Once I go past like 2 beers. So if I'm stationary, I don't have the breathing problem stationary. But if I'm trying to walk anywhere, I feel.
A group of us are going out, and we walked quite a bit down the river walk, and I thought we had concerns. I said, Marcia, I'm done, I'm toast.
I knew that I was going to consume at least a glass of wine or whether or not it was a beer, and that I would have difficulties coming back. When I'm in a position that I know I'm going to be out socially and having a great time, I have a designated arm, which is usually my husband. So that's my little crutch, and I know that I can expand on that. But like Tiffany, I do notice difficulty in breathing, but I also have asthma and allergies. So I attribute the alcohol intake due to the allergies, and I take care of that by taking allergy pills, and then I'm good to go. So I tend to enjoy my wine quite a bit. I will admit, yes, I am a wino, but and maybe I have a high tolerance because of that. But I can't say one way or the other. It really depends on how well I sleep that night. So, yeah.
Jenny's not on treatment yet, but I was just wondering, those of you that are on treatment, how accommodating have hospitals been to try to find a local facility that can do the treatment, that you don't have to at least drive hours on top of the hours that you have to spend in the hospital?
Gary. Yeah, Gary. Questions be directed to Gary. He just walked out.
Gary?
Oh, okay.
From my experience, it's not going to be the hospital. It's going to help you find someone who can do it. It's going to be Genzyme. It's going to help you find an infusion center. And they worked with me, and I moved out of the hospital setting, and I'm at an infusion center. If you all saw the table set up by Quorum out there, they're an infusion center, and they have sites all over the country. And that's where I get mine. And the hope is to eventually, hopefully, transition home to home infusions. But I'll let...
No, Gary's here.
He didn't hear
Somebody's going to have to repeat the question. I'm not sure what the question was.
The question was on transitioning out of the hospital setting, and who helped with that?
No. My question was, in our case, we're not getting treatment yet, and with the amount of time spent in the hospital, especially with my situation where Jenny can't travel, she can't drive, I have to take all the work. And I was just wondering how accommodating the system is to finding a local hospital that can...
Okay, I think I can answer that. I think I can do it without the microphone. You can all hear me?
Yeah.
Good, okay.
Well, we want to be able to hear it on the tape.
Okay. Well, my suggestion would be this. If you're going to start therapy, you have a patient care liaison that covers your wife's area. There's a Genzyme treatment support person in Boston, and there is a clinical science associate in the field. And those three people are your core team. They will find your wife an infusion center that is the closest one to you to begin with. If that is not closest enough, that we will attempt to develop a infusion center or a physician to infuse your wife. And then in terms of transportation, one of my patients is a student at UCLA, and she's from Taiwan. And so she's here on her own. The MDA provides transportation for her to her infusion, and then the city of West Hollywood, where she lives, provides van service to pick her up and take her home. So I was able to make those connections for her as her patient care liaison because she was having some transportation difficulties. But each infusion center is different, and each infusion center, depending on their expertise, will provide you with certain perks, if you will. I hope that answers the question. It's a general response, but each infusion center in each state, and certainly in all the different countries, are going to be very, very different.
A general question for patients. I see a lot of discussions about people support networks and kind of the medical network, but and maybe this is more for the U.S. patients, but I feel like I've got a primary care physician in my HMO, and
I see him and he gives me penicillin or whatever I need when I'm cold. But really, when I go see him, I got a 10-minute slot, and he knows I have Pompe disease, but he doesn't know what that is, and and then so I have one relationship with him, and then I go to get infusions at a hospital, and there's a geneticist who is the head of the program and knows me, but really she's running the center, and I don't really have much of a relationship with her either. So I kind of feel like I'm just doing everything on my own, or at least trying to direct that process, and I'm working through the system to get whatever insurance stuff I need, and the Genzyme GTS books are great on that. But really from a care standpoint, I'm really, I'm not getting care, I'm getting, I guess, the enzyme. But I'm wondering, do people really have a network of people, medical people they talk to and rely on, or it's pretty much just you go and you're doing it?
Yeah, I do have good physicians, but regarding the rehabilitations program, I also found that I needed to develop it myself. So actually I looked around, and I live close to a rehabilitation center, about 50 kilometers away, and I was there already. And I was so lucky that they wanted to have me, at the children's rehabilitation department. And I was lucky because they are more dynamic. And together with them, I'm now trying to find out what my best way is. But I really had to go to them. And because first I didn't have, my rehabilitation doctor just went away, and I didn't know where it was. And I thought, my gosh, no, I don't have one. And I went up, and I was trying to find a new one. It was so difficult to get access to someone, and I finally, thanks to the Center of Medical Home Mechanical Ventilation, I found one again, and she was ready to support me. But I really had to find and actually design the rehabilitation program myself. And I think it's quite logical because everyone is working hard and making the treatment possible. But since I'm already a bit ahead on many other patients, I am in need for other things like rehab programs, and they are not developed yet. And I think that we need to develop it together by sharing ideas. I thought when I remembered a presentation of Nina Raben a while ago about that the diaphragm was reacting pretty good on my enzyme, and I thought, okay, so I have to train my diaphragm, but how am I going to do that? So since September I'm taking singing lessons. It's really nice, and maybe I will get a musical instrument, like a saxophone or a clarinet, I don't know what. But these are just ideas, and you can try to figure out yourself if it's an idea or a good idea or not. And that's how I try to do it. And for sharing on GSD.net and just situations like here, I think you can do it together.
I have a son that's affected. He has classic infantile Pompe. He's 4 years old. He's on ERT. He's been on ERT for a little over 3 years. He has an infusion port. He has a gastrostomy tube. He has a ventilator. He just went to get a power wheelchair. So he has a tremendous need for obvious reasons, insurance coverage. Recently, Genzyme has sponsored a case manager. So for anybody who has these kind of needs, case manager is imperative. There's a lot of questions that come up with all of this equipment, much less all the other additional equipment that follows that. So there's a lot of money at stake. But the case manager, I believe the company is PHCS, Primary Healthcare Systems, I believe it is. Margie Rosenthal is our case manager, and she's great to have somebody advocate the insurance companies like that. She's a real watchdog. She finds anything that's not right, tells us about it, and then coordinates the insurance company with Genzyme. So she is definitely a necessary link. So if you can get a case manager, I definitely recommend it.
And you have to be aware of that. You have to do that. You have to follow your own case. And what I would like to encourage is to share your experience. Each small piece of information may be valuable for the whole community. Don't think local, don't think American, just think worldwide and share your experience. So we contact to roughly 100 patients, 80 of them are on therapy, and we get reports from the patients, phone calls, or written reports on a regular basis. This helps us to pick up the feelings out there, what's going on in therapy. And I would encourage you to do the same. Just write on GSDNet on a daily basis or weekly. Send reports to the AMDA or IPA, and I think it would be a good idea, maybe managed by IPA, to put this together into a big data, kind of a database from experiences from patients, just some keywords, breathing, diaphragm, and so on, so you can pick up the information that was collected on an individual basis. This would be great help, but it depends on your help. So when you're on therapy or not, or you're on your way to therapy, I've made some experience, just share it, report it anywhere. So there are lots of ways to share the information, but you have to do it. You have to do it not only once, but again and again.
So is it Brian? Sorry. Do you have a specialist? You said you have primary care, but do you have a specialist? Like a cardiologist or a pulmonary doctor?
I saw a pulmonologist once, but...
Bailey's pulmonary doctor, they work as teams, and he seems to be very well involved. I didn't know if that was because he was a specialist. Maybe they would be more interested. They seem to work as a team. They have pulmonology, a pulmonologist, a nurse practitioner, respiratory therapist, and a social worker. So it really works well. I don't know. A specialist would be better.
I think it's pretty typical that you do not have a team. Maybe that's something that would develop in the future, but we never have had specialists. In fact, we've been to pulmonologists that we felt weren't treating the disease right. They were treating her for another lung disease. And neurologists, no. The only person we relied on was our GP, and it was mainly because we just have a rapport and a friendship. And she would say, I'm going to treat the patient, not the disease. And if she was sick with something, whether it was indicated for Pompe's disease or not, she would do it until she got well. And that's what we relied on.
I think I would say that we have to be our own experts, and we have to know and give the information to our doctors, because it is so rare that they're not going to know. I mean, we've had patients that I had a pulmonologist that treated me as if I had cystic fibrosis, because that's what they knew. And so you can't, they put you in a category, and that's how they treat everybody. So you have to be your own advocate and know what's going on and take the information to them. If I go to a new doctor's appointment, I have a stack of brochures, and I say, this is Pompe. This is what you need to know, and then next time I come back, maybe they'll have read it.
Well, I'm one of these medical people that just had something to say. I'm a nurse, and I probably have told 6 million patients in my life that you have to be assertive, particularly women. If you go to a physician, they're going to categorize you to a certain extent and chalk it up to your hormones. If you feel a certain way, you have to communicate that. If you don't do it, you will get blown off and put in the corner. That's just the way it is.
I would like to give a special thanks to myself for being here and leading. Thank you very much for this meeting.
Where was that? Anyway, I just want to encourage you to be assertive. And I have to go along with what Tiffany said. You have to know your disease, and you have to know a lot about it, and you have to be able to communicate it. And you can't get angry because we don't know what you're talking about. And we're going to look at you like you're nuts, and we're going to look at you like you don't know what you're talking about. Expect it, and don't get upset. Because part of your job is to educate those people whose job it is to help take care of you. And the first time that I met Tiffany, I knew this much about Pompe. I learned fairly quickly what it was, but I also had got information and read and looked it up. A lot of us don't have time to do that on a daily basis. So when somebody new comes into the door, the best that you can do for us is to give that information. To feel like you're a partner and to just say you probably don't know anything about the disease. Let me help you learn some things. The blah, blah, blah. You got the idea. It's not an insult. But if you have a caregiver who really is not responsive to your needs, then you need to deal with that issue. You don't have to take it. You don't have to take somebody who is abusing you. There are systems in every facility, whether it's in a clinic or in a hospital. There are patient advocates in those facilities as well. And you do not have to be subjected to poor care. If you don't feel like you're getting what you need to address it. There's generally a head nurse that you can go to first. So I would suggest that you utilize those things. Again, not in an aggressive kind of way because, we're all human. So if you're mean to me, then what's the usual response? Is I'm not going to be too nice to you. One of the other things I wanted to say, how many of you have ports, or how many of you are accessed every time you have to have an infusion? Are most of you accessed individually? Okay. Do they have trouble getting your IV started? Okay. There's just a couple of things that, having started well over 1 million of these in my line, I would like to suggest to you. Number one, you want to be well hydrated when you go to the hospital. Number two, you want to be warm. I do not care if it's 110 degrees outside. Do not wear shorts, wear a sweatshirt, long pants. You can bring your other stuff with you. But before I stick you, you want to be warm. Now it's a whole lot easier to find a vein in a warm arm. Okay, so think about it. Usually if you're warm, and I know Tiffany and I have gone around a few times, and she comes in half naked, and we don't always get it the first time. So, and I've told her 100 times, you need to be warm when you get here, but, she has her own idea. So you can do some things to help yourself, okay? All right, thanks.
Just a comment. We've been working with the same pulmonologist for 16 years since Jenny first was diagnosed, and we've actually learned together. He admitted at the time when she was being mistreated for polymyositis, they put her in the hospital overnight for a megadose of prednisone, and she went into respiratory arrest. Not knowing any different, they tubed her, which they had to do. And but unfortunately, then they gave her a trach, which it took her 6 months to get off of. So, but we gained a relationship with him, and we all learned together. And when we finally heard of Dr. Bach and wanted to go see him, we told our doc what we wanted to do, and he said, I really don't think is the right way to go, but he said, I'm game. So that's what we did, and he supported us. And in fact, it's been 2 years now, and he has 3 other patients that he's now has on ventilator with non-invasive support. So it does work. And also the other thing, this summer, Jenny just about choked to death on a submarine sandwich, and we got called an ambulance, and we were about 20 miles from home. And in fact, I instructed the EMTs of her condition, and they said, we don't do this much, but you come with us. And that's kind of the relationship you have to do. And they said, without you, we would have never known. So it's just something you have to do.
Why wasn't she wearing a medical alert bracelet? Oh, okay. Well, my parents got me one for Christmas, and this is a very good point I'd like to bring up. I wear it on my left arm, and my parents, being the kind of generous people that they are, went onto the internet and found this, purchased it, but they went to the wrong place. Bless their hearts, they thought they were doing a good deed, but there is a specific, and Linda, you can actually go into detail, because Trevor wears this special bracelet. It's a Medic Alert bracelet, and it has a 1-800 number on it, so that you can put a few details, whether you're allergic to medications, that you do not require oxygen saturation, BiPAP necessary, emergency contact phone numbers, depending on the size of the medallion, because you can have it on your neck, your wrist, gold, silver, stainless steel, platinum. Yes, actually I've got a beautiful French twist one. They can range anywhere from $14 up to the one that I wanted, being the princess that I am, was $850. And they're very easy to get. Is it an annual fee, Linda?
For kids, it's a one-time
Okay,
fee,
yeah.
and now they've just came up. It's I don't know if it's $20 or $30 a year.
Yeah.
But kids, they just ask for a donation.
And for $35, you can have that sense of comfort knowing that if you get into a situation and your caregiver, partner, family member is not there to say, hey, do not oxygenate this person, they require mechanical ventilation, blah, blah, blah. It's the best thing to do. And so I need to get mine changed a little bit, but it is, and Linda, maybe you can give the detailed information.
Yeah, can we put that on the website?
Yes, good idea.
What it is, you know, in Canada anyway, you have to pick it up. A doctor fills it out, and then it's sent in, so it's totally 100% true to what's going on. And it comes in everything, very elaborate, gorgeous looking jewelry, to the one that's going around. That's a sports bracelet. And
It's a worldwide service, too.
it is a worldwide service. And then another thing we did when Trevor was diagnosed is we went to our GP and said, Trevor has Pompe disease. Do you want to look after him? And he said, I'll be there for you. And one phone call, he will come from anywhere and look after us. And now we're blessed with Dr. Casey, and he's a specialist, and we have that kind of care. We're very fortunate. But I would really recommend some of you all give this kind of bracelet. Another thing we do for Trav is in the back of his wheelchair, he has emergency letters from his doctors telling him do's and don'ts. And if he takes an ambulance ride, one of us are with him. They don't even hesitate. And you can just tell them this is how it is, and they will do it. It's amazing.
To centers which have experience with Pompe, but we have tried to help as many as possible in the US, and we have had many phone calls, and some where they've actually come, and we have a team approach where we have specialists who are involved in pulmonary, in cardiology, in anesthesia, in physical therapy, in all the different aspects. And so if any of you really are in trouble or really need a physician to talk things through, or you're not getting the point across, do not hesitate. We have done this over the years, and we are still happy to continue to do this.
Well, it's 2 o'clock. 2 o'clock. Anybody else want to last chance for anything else? Anything you're itching to
Is
say?
that going to be put on the website, the address of this bracelet?
Yeah.
And
Yeah.
likewise,
Yeah, I just wrote it down.
the phone number that we can call for that kind of assistance?
Yeah.
Yeah, and it's a toll-free number worldwide, and it's total access by any doctor, any emergency person.
Well, thanks everybody for coming.
Thank you. Thanks for everyone. Thanks for coming, everyone. I think it's the last team of conference, isn't it? So I hope you all have a good travel back home, and I hope to meet many of you on GSD again. It's really great to see some of you for the first time in real life. So that's it. I think it was good. So thank you all.
Marcy, do you want to make sure that everybody is aware of the GSD net?
Yeah.
Is everybody signed on to receive information?
No, she gave us that information.
Oh, boy. I don't know how to do that. Can you get me your email address? Yeah. We'll get you on that. It's a forum, a chat forum. You might want to specify what type of glycogen storage disease you have when you do register, because you will get numerous types from type 1 to type 9. So you may not want to read everybody, but it is helpful knowing that there are others out there that actually are far worse than we are as Pompe patients. I think the Carlos patients are heroes because of the pain that they suffer. So I'm their little champion. The parents that, type 3 that have to have cornstarch every 3 hours to feed their children. So it's a great way to
Aren't there directions to get on the GSD net through AMDA, through the website, on instructions? Yeah. Yeah, webs of interest, yeah. Through AMDA.
So thank you everyone for coming. I wish you good travels back home, and I hope this
And good health.
a very good health.